Good morning. My name is Akarin Hiransuthikul, and on behalf of all co-authors and all the study staff, we would like to thank the conference organizer for selecting our work to be presented here today. And today I'm thrilled to have a chance to talk about the latest finding from our study, the IFAC-3 study, which today I will focus exclusively on the PBMC and urine analysis. Some disclosures. Our study was supported by an investigator-sponsored research grant through Gilead Science. And I think everybody's agreed that it is established fact that PrEP works. However, there are still some concerns, such as the potential drug-drug interaction between gender-affirming hormone therapy and PrEP, in which Dr. Chakapat has kindly discussed in the previous section. And this point can limit the uptake of PrEP among transgender individuals. Some studies, including our own as well, have suggested the use of feminizing hormone therapy may somewhat modestly reduce the tenofovir and interchange concentration among transgender women who used TDF FTC-based oral daily PrEP. Although the clinical significance is not expected, at the very least, for daily oral PrEP use. The newer form of tenofovir, TAF, can achieve higher levels of active forms of tenofovir intracellularly within target cells. So theoretically, this should mitigate any potential drug interaction if there is one. And last but not least, the Discover trial have shown us all that daily oral FTAF was non-inferior to the TDF FTC for HIV prevention. Moving over to our study, the IFAC-3 study, the overall picture of our study is to investigate whether there are any drug-drug interactions between FTAF-based PrEP and feminizing hormone therapy among transgender women. Now, what we did for pharmacokinetics parameter is we measure 4 compartments: plasma, PBMC, urine, and rectal tissue. Now, for rectal tissue, unfortunately, we don't have that data right now. We are eagerly waiting for that. The results should be in within the next 2 months. PBMC and urine results will be discussed today. For plasma results, we had a chance to present it in CROI earlier this year. And I can go very briefly here, and then you can see that there are no significant differences in tenofovir levels. Let me rephrase that. Plasma tenofovir and emtricitabine level among transgender women who use FTAF-based PrEP with or without using feminizing hormone therapy. Now, the statistically significant differences were observed on the exposure. So here you can see on the right-hand side of the table, the AUC row, both the AUC area under the curve, for the tenofovir and emtricitabine as well. There seems to be statistically significant differences, but when we look deeply into the GMR, stands for genometric mean ratio, you can see that the difference is only around 8%. So with these very minimal changes, clinical significance, again, is not expected. For today, I will be talking about the impact of feminizing hormone therapy on the intracellular tenofovir diphosphate and emtricitabine diphosphate concentrations in PBMC, as well as the tenofovir emtricitabine urine concentrations. In our study, the IFAC-3 study, 20 HIV-negative transgender women who had not undergone a correctomy were enrolled earlier last year. This is one of the key points for our study. Every participant used the same hormone regimens. So what we prescribed was estradiol valate 2 mg plus cyproterone acetate 25 mg. And for PrEP, is of course FTAF. And I want to shift everyone's attention to the right-hand side, to the IFAC-3 study scheme. I think this is very, very important before we can move on to the results section. So for the IFAC-3, and actually for the IFAC-1 and IFAC-2, which we had conducted almost half a decade ago, make me feel old a little bit, times fly. We do the same thing in that we do a two-way analysis, meaning that we want to investigate whether hormone therapy affect PrEP, but also vice versa, whether PrEP affect hormones as well. And what we did was, how we achieved is like this. We start everyone on hormones, only, no PrEP, just hormones. Wait for 3 weeks, do the first hormones level. And that hormone level will give us the levels without the PrEP in the body. After that visit, for this study is week 3. After that, we initiate PrEP. Again, for this study is FTAF. Wait for the 6 week, and we do the second hormone measurements. And that second hormone level will be hormone level with PrEP in the body. We do that similar fashion for PrEP as well, but in opposite direction. So the first PrEP measurements The first PrEP level will be PrEP level with the hormones. So these are at week 9. After we collect the PK sampling, we stopped the hormones, wait for another 3 weeks, and do the second PrEP measurement. So that second PrEP level will be PrEP level without the hormones. And for today, talking about PrEP, we're going to compare week 9 and week 12. Again, week 9 is PrEP level with hormones. Week 12 is PrEP level without the hormones. And when we compare, we can see whether there are any changes in the presence and absence of the hormones. For PBMC sample, we collect at 2 and 24 hours. And for urine collection, we did a 24-hour urine collections. Move on to the results. So out of the 20 participants, 18 participants completed the study visit and were included in the analysis. The 2 participants who were unable to come back to follow visit was due to personal reasons. The median age was 28, median BMI is 20.8, and I'm going to start off with the result from urine measurements first. The urine geometric ratios, week 9 over week 12, aka week 12 as the reference, shows that there were no significant differences in both tenofovir levels and emtricitabine level between the 2 weeks. Again, between the weeks, as in week 9 is PrEP level with hormones, week 12 PrEP level without the hormones. So no significant differences from the urine markers. Moving on to the last part, and that is the PBMC results. I'm start off first with the tenofovir diphosphate. You can see the PKM parameters. We have 2 time point, concentration at 2 hours and concentration at 24 hours. But regardless of the time point, there seems to be no significant differences in the tenofovir diphosphate level in PBMC between the 2 visits. The same thing can be said here for the emtricitabine triphosphate in PBMC. Similar fashion, 2 time points, but regardless of the time points, no significant differences between the 2 weeks as well. So, in conclusions, intracellular tenofovir diphosphate and emtricitabine triphosphate level in PBMC, as well as urine tenofovir and emtricitabine concentrations, were comparable when FTAF-based PrEP was administered with and without feminizing hormone therapy, suggesting no clinical significant drug-drug interactions from feminizing hormone therapy towards FTAF-based PrEP. And as mentioned earlier, tissue rectal measurements of tenofovir diphosphate and emtricitabine triphosphate is ongoing, and we were very excited for that results. Lastly, I'd like to thank all the participants for their dedication to the study and all the study staff for their tireless effort in taking care of the participants. And before I end with saying thank you, I would like to tie in announcement/advertisement that APACC 3, of course, is the 3rd study we did in a fashion of checking the drug interaction among transgender women. Tomorrow, at the late breaker abstract session, Submit Room 2, 11 a.m. sharp, we're going to, very excited to present for the first time the latest finding in the drug interaction studies for transgender men. So we are very excited about that, and hopefully I will see everyone again tomorrow. Thank you very much.